I'm Joe Tyler, and we're here with David Calairio, who is a clinical program planner of the Division of Public and Behavioral Health here in Nevada. Are you stressed out, wigged out, freaked out, feeling anxious, angry, or depressed? Want to know how people with real mental health problems learn to cope? Keep it right here and get the latest word from experts in the field like me, Joe Tyler, a consumer service assistant at the Dean Townsend Hospital, a speaker for the cause for mental health, as well as a state of Nevada and president. Here on Racing the Stigma, take you, the viewer, into the brain's biochemistry that is mental illness and bacteriology safely. Here on Racing the Stigma, we find hope for people whose lives have become unmanageable. So stay with us for the next half-hour segment as we begin to erase the stigma for people with mental illnesses. Here's David Calairio, who has a compassion for doing his work as a result of a family member early on, but didn't realize it. Like me, I have a great uncle, or had a great uncle, and my mother would not talk about it. You know, it was really sad. So tell us your personal stuff that.
Thank you, Joe, and thank you for having me on your show, Joe. I'm very honored and humbled to be on your show. What probably got me the compassion towards persons with mental illness was an experience I had as a young child with my own grandmother. I was growing up very close to my grandparents, and I always wondered why my grandmother had chronic illness and all, and I always wondered why she was so sad, always so depressed. And as a young child, I didn't really realize why, but as I got older, I realized that my grandmother was clinically depressed. And it did affect the family in terms of its functions, and that grandma was always different from other folks. So even as a young child, I knew that something wasn't right. And as I got older and realized that the woman that I loved and played an important role in my life was clinically depressed.
Yeah, okay. And then we know, NAMI knows that I've seen studies that if you have alcoholic parents or depressed parents or whatever that kind of thing, it kind of affects your stability and personality yourself a little bit too. So, but good thing we're all survivors and fighters. But yes. David, now let's see, you how big is the job from a state standpoint of getting 1,000 more people that can provide Medicaid types of interactions with people?
Yeah, it's a big job, Joe, but it's a job that's very worthwhile. We're fortunate in terms of we have an opportunity to serve clients that are Medicaid eligible, including the Medicaid expansion. Medicaid obviously is taking a key role in this and exercising the resources that they need. In terms of what we're looking at for behavioral health, and I might add, by the way, that a real good decision was that mental health is being incorporated or integrated into public health, and our new name is now the Division of Public and Behavioral Health Services, which is great because now we serve the whole person. We're in one division that can serve the whole person, their physical health needs as well as their behavioral health, their mental health and substance abuse. For example, one example, Joe, that we're looking at is our SAPTA, which is the Substance Abuse Prevention and Treatment Agency that's within behavioral health, is already starting to train some of their providers who have not historically been Medicaid providers to prepare them for the Medicaid expansion and the Medicaid opportunity for service and billing provisions. Authorizations in some cases will be needed, and being able to keep that financial flow is very important for our providers. This is a new field for them, but it's big for Medicaid, it's big for us, but it's a very healthy challenge for us.
Yeah. Well, and especially because we're trying to put together, we've been trying to do this for years and years and years, a no wrong door approach to mental health, to physical health, and to addiction services. And I think that when I sat down at one of the workshops we had, there were people at the table that were from Las Vegas that were completely coming out from a different point of perspective than I would. It was dual recovery people. So they're talking about addictions and health issues, and it's a great step forward. I'm not sure.
Absolutely.
Is each Medicaid provider going to be having his or her own kind of like strength, or how will the diagnosis groups be, DRGs, they call them, drug-related.
Right. Yeah. Well, there is, for example, Joe, there's several things going on. The ICD-10 coding is coming out. That's going to be very crucial because that will update billable services, codes to be used. Also, what we call the DSM-5, which is the Diagnosis Statistical Manual for Mental Disorders, is being upgraded as well. So that gives opportunities as well to get the most current information in the hands of the providers that need it both. And when you couple that with the training they'll be getting, and all surrounded by healthcare reform, I think it is very, very big and huge. And I think it will transform behavioral health services that we know it, and especially not only nationwide but here in Nevada. Yeah. We're just excited about it.
And 1,000 people, that's a lot of people to train, And now, who are you looking for? Those people? Are you looking for like a CSAs who are consumer service assistants because we have an illness? We're able to help other people accept that, or are you? I mean, what kind of?
No, I can give you an example, Joe, where we do want to look at peers, consumer assistants or peers, to be able to not only provide services and be the colleagues that they are, and working with treatment teams, but also for their services to be Medicaid billable. We are looking to transform. We're getting federal technical assistance on how, for example, to transform our peer services in Nevada. It's not only our agencies, but for community providers as well. So we want to provide our peers, we want to first build a network of peers, and when I say peers, I mean both on the mental health and alcohol and substance abuse side, and that would include co-occurring disorders. We would like to have our peers certified, go through training to get them certified. And then ultimately, part of our big plan, strategic plan, is that those peers will be trained and it will meet the qualifications to be Medicaid providers. We're very fortunate in our state that Medicaid does cover peer support or consumer support services. So we'd like to integrate them and have them work alongside psychiatrists, psychologists, social workers, traditional mental health, and be accepted and looked upon as colleagues, because that's exactly what they are. So we do have big plans over the next year for our peers.
That's big, because I don't know, the growing pains with regard to CSAs, it's the movement's 15 years old, about, or 12, 13. I was the first second CSA to come on board. And man, my peer or my coworkers had trouble accepting me a lot because, do I treat you like a patient? Do I treat you like a provider? But I think we're working it out better.
Absolutely, we are.
Time to do.
Yeah.
Well, let's see. What are the kinds of things? We worked on legislation with regard to the tobacco fund settlement. And we're able to get $16 million that the governor approved to do like a private home project. $2 million for a home health. Do you fall into the home health stuff? Is that a longer ways away? Or?
Medicaid is working on a couple of things in that regard. Health homes, I think, is what they are. And these are not physical, as they sound, like a group home and all. But again, this would be, it would be a location where folks can go to and get all of their needs met, their physical needs, their mental health needs, behavioral health. We have qualified health centers that also provide some of those services in Nevada. Health homes would focus on folks that meet certain criteria, that they have certain chronic illnesses, and that also mental health and substance abuse is included in that, which is, again, we're finally reaching, Joe, parity with behavioral health services along with chronic diseases. And Medicaid is also working on a project for those folks that maybe would not meet the criteria of a health home, but they call them CBOs, CMOs, community management organizations or care management organizations, which would be a very high level of case management as well. So Medicaid is working on that. They've submitted a waiver to the feds to get those services approved. I believe at this point that has not yet been approved, but again, we're hopeful that this will be, because we would also like to see our peers in these health homes as well. We'd like, once we get a peer network developed and we get folks trained and certified, again, not just the state agencies, state mental health agencies, but all of our community partners, private organizations, health homes. We'd love to see them reach out into schools over time too. So we would like to get peers trained, certified, Medicaid reimbursable as providers, and then have them in agencies and organizations, and again work along their mental health colleagues to provide services.
Yeah. And so, thinking about that, President Barack Obama, with some of the last awful things have happened with people with mental health issues, turning guns on people and doing crazy stuff. I understand he put money from the federal government to help put in counselors in the schools or guards or security guards or pound counselors. Is that part of the state's work, or is that passed down to the counties, or Did you heard of any of that stuff?
Yeah. Well, what we're in terms of healthcare reform, that could be a combination. For example, our hospitals do have security guards, and several of our mental health centers do have security guards that are on the premise. And we are, as you know, we've worked with your organization, Joe, with NAMI, and the good work you're doing. We are promoting safety with firearms, and we want to tote the line between erasing the stigma that anybody has the potential to commit a very serious act or a very deviant act that way. It's just not persons with mental illness. We don't like to see them stereotyped. So what we're looking at, for example, in some of our intake and assessments at our agency, for example, not asking people if they own guns, but asking people if there is access to guns wherever they may live, whether they live by themselves or with other folks. We're also reaching out to organizations like yours to provide gun safety locks, to provide outreach and education on gun safety, and again, doing it in a respectful way that does not at all stigmatize persons with mental illness.
Well, I don't know. Is there anything you'd like to add? I can't think of. It just looks so optimistic. I mean, but that's it. You got to look at the cup half full.
Absolutely, Joe. And what I would like to add, Joe, too, is with our integration into public health, the public health model is very community-focused, community-based. And MHDS, as it was known, we would primarily support our agencies and our state agencies. We're still doing that, but we're also reaching out to community partners like yourselves, like the coalitions. We have a number of coalitions throughout the state, and we're doing more work than ever. Not only are we providing treatment for mental health and substance abuse and co-occurring disorders, we're also, Joe, doing behavioral health promotion, prevention, and awareness. We're getting involved in the community. We're participating, like, for example, in your NAMI walk, which is a great opportunity, community opportunity. We're running inserts on promoting the positive aspect of mental health and not the negative. We're providing resources. We're doing more prevention work, and the coalitions and organizations like yourself will help us. So I did want to emphasize that in addition to outreach in the community, we are providing more information, prevention, promotion on the positive aspects of mental illness and trying to destigmatize folks, and working very closely with the healthcare reform initiatives. We're very fortunate, for example, that there are 10 essential benefits in healthcare reform, and one of those is mental health and substance abuse services. So parity for the very first time is very important. So I think we have been making...
And NAMI spearheaded that on a national basis. But I think in Nevada, for insurance purposes, though, I think that there's still the numbers of employees that are employed in an organization, if they're 10 and under 10 and over 15, there's a big segment that's cut out there. And I'd like to go back and re-examine that at some point, because a lot of employees can't afford it when they have real little offices, and on parity. But parity, that's another issue. So
yeah, absolutely.
I don't know. I think is there anything else you can think of?
Well, no, I think, and again, I appreciate the opportunity. We have, it's a lot of work ahead of us in all, and we've done a lot of things, so we have more work to go, but we're very pleased with the direction we're going, Joe. We're under the leadership of our administrator, Mr. Richard Whitley, again, incorporating the public health model of behavioral health services, mental health, and substance abuse, I think is a good thing. And the fact we're reaching out to communities more, and we're doing the promotion, awareness, and prevention. The coalitions have done that throughout the state for years, for all ages, for school-age children, for adults. So we're utilizing them, and they're including us. So it's a great partnership as we kind of expand and take on a new role than we've ever done before.
Yeah. Okay.
Yeah. Thank you very much.
Great job.
Thank you.
Thank you. This is good. All right. Thanks, Guy.
Oh, you're welcome, and thank you. Other than just for those first few minutes, I know it's